in surgery?
You're muted, Chris.
Yeah. Looking at like physician sex and surgical outcomes and.
Perfect. Okay, so we'll switch gears and we will hope that she joins us. And if she doesn't, that's too bad.
Okay.
Okay, I guess we'll, she said, I'm having trouble connecting. Are they running behind? Oh no, that's from people asking me what's happening.
Yeah, that's
Okay.
the people
Open
that
it
need
up.
All right,
to.
we should probably open it up.
Okay. All right. So I'm going to open it now. If anybody needs to communicate a technical issue, you can do that through the chat to hosts and panelists, and that way only we can see that. Okay. All right. I'm going to open the room right now.
Okay.
Give it a minute or two. Let them populate.
Okay. I see the numbers rising. I think it looks like we've plateaued for a moment at 42. So maybe we'll get started. Thank you everyone so much for taking the time to attend our EDI session today. We're sorry about the late start and the little glitch. The little glitch is because our speaker, Dr. Argavan Salas, is not yet here. So we were giving her a little bit of extra time while trying to reach her. And so we've decided to, while waiting for her to join us, take a slightly different direction, because that's what we do in surgery, is we deal with the situation that we have and we make it even better than the original plan so that everybody gets what they want out of the situation. So taking a little bit of a turn. And we have a knight in shining armor, which I'll introduce in a moment. So today we wanted to focus on a topic that is very near and dear to my heart as a female surgeon. We wanted to focus on gender equity and gender surgeon concordance in surgery and patient outcomes. Before I introduce our new keynote speaker, I would like to take a moment to do a land acknowledgement. We recognize that the Tamarti Faculty of Medicine sits on the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the New Credit River. We respect the long-standing relationships that Indigenous nations have to this land, as they are the original caretakers. We acknowledge historic and ongoing injustices that Indigenous peoples endure in Canada, and we accept responsibility as a public institution to contribute towards revealing and correcting miseducation, as well as renewing respectful relationships that Indigenous communities through our teaching, research, and patient care. So with that, I would like to let everyone know what our new agenda is for today. So we are very lucky to have Dr. Christopher Wallace with us, who is the first author of a paper that has received a lot of attention here through the U of T community. Dr. Wallace is a urologist here in the University of Toronto, and his research focuses on leveraging a variety of epidemiologic techniques to understand the interaction between processes of care and patient outcomes, with a particular focus on patients with cancer and those undergoing surgery. Recently, his work has focused heavily on understanding the interplay between physician characteristics and patients' post-operative or operative outcomes. And we are very fortunate to have him today to pinch hit and maybe just give us a brief introduction to the paper that I was referring to, entitled The Association of Surgeon-Patient Sex Concordance with Post-Operative Outcomes. And we also have Dr. Argavan Salas that has just joined us as well. So we sort of switch the order a little bit, Dr. Salas, if you don't mind. I just introduce Dr. Wallace if he gives a 5-minute or so introduction to his paper, which we wanted to discuss in our panel today. And then maybe we'll come back to you and I'll introduce you as our keynote speaker. Is that okay? Great, perfect. All right, Christopher Wallace, take it away, and thank you so much.
Thanks so much for the chance to join this group. I expect that I will learn more from the group than I have to offer, but I want to, take maybe a moment to discuss some of our recent data. This fits into a greater context of a body of work that we're trying to develop. But one of the things that really has struck me, and Angela Jareth is on the panel as well, she's one of my sort of close collaborators on this work, is that when we think about surgery, the traditional focus has been, I think, maybe a little too narrow. We focus really on surgeons and surgeons' characteristics in isolation when we think about surgical outcomes. And fundamentally, while we operate in a healthcare system, we do operate with a real relationship with our patients, and we have to consider the societal context in which frames the way that individuals interact. And so this is the paper that's got sort of a lot of interest and a lot of press recently. And you can see Dr. Jareth there is the second author, and a lot of sort of other really smart people have helped contribute to this work. And what we wanted to look at was whether there was an association between surgeons and patient sex when we look at postoperative outcomes. And this is really premised on that idea that medical outcomes are shaped by the sort of biopsychosocial environment that we all interact in, and the assumptions we maybe make about people we're interacting with and how we may communicate differently. And so we looked at sort of our standard battery of outcomes. We have a composite endpoint that encompasses death, readmission, and hospitalization, as well as major medical complications. This is the same endpoint that David Erderbach used when he was looking at the rollout of surgical checklists in Ontario, or Anand Govindarajan and Nancy Baxter used when they were looking at the effect of surgeons operating the night before their elective cases. And so this is what we thought a pretty validated outcome. And what we saw was that when there was a discordance between the surgeons and the patient sex, that outcomes were a bit worse. And this, as you can see, is relatively consistent between death, complications, and readmissions. But this treats male surgeons interacting with female patients and female surgeons interacting with male patients the same. And so the sort of more notable part of the analysis is here. And this is, I think, what's gained a little more interest and a little more traction. And what you can see is that among male patients, overall outcomes aren't that different on the basis of their surgeon sex, although we do see somewhat lower mortality rates for male patients treated by female surgeons. And that goes back to a previous paper we put out about 4 or 5 years ago, showing that overall patients treated by female surgeons do a little bit better. But the interesting part here is that among female patients, there is a disproportionately higher rate of these adverse outcomes. And so female patients treated by male physicians have a 15% higher chance of the composite endpoint, 32% higher likelihood of 30-day mortality. And you can see with that test for heterogeneity, or the interaction test in the bottom row here, that this is not just explained by the fact that overall female surgeons are getting better outcomes for their patients, but there is really an interaction between male and female patients with their surgeons in a way that really, I think, speaks to the interactions and communication relationship between patients and surgeons in a way that is more meaningful than just looking at surgeons practicing in isolation. And so for what it's worth, there's one other example out there of people who've looked at this and looked at a similar idea. And so this looks at patients who present to the emergency department with a heart attack. You can see in that blue line that overall patients who are treated by female emergency room doctors fare better than those treated by male doctors, and that that blue line is relatively flat, which is to say that whether you are a male patient, which is this female patient 0 on the left, a little bit of an odd way to represent it, or a female patient, which is the female patient 1 on the right, the outcomes are pretty comparable when they're treated by a female emergency room doctor. But when we look at patients treated by male physicians, the male patients fare a bit better than the female patients. And so we're really seeing in other aspects of medicine a similar idea. And I think that really speaks to why there's been some societal and lay public interest in this work, because I think this isn't a surgery observation. this is not even a medicine observation. This is probably a societal observation. And I think that's why the work that Dr. Salas is doing is so important, because this really doesn't operate just in our ORs. This doesn't operate in our hospitals. This is a greater sort of societal issue about how we interact with our colleagues, how we interact with our patients, and really how we want to build our specialty in our field. I think now is a good time for me to probably hand it over.
Thank you so much. That's actually perfect to set the stage in this way, because I was hoping we could discuss the paper a little bit during the panel later on. So now we're all starting with the same introduction and knowledge of the paper. So thank you. And we do have Dr. Salas here now. So I'd really like to just take a moment to introduce our keynote speaker for today. Dr. Argavan Salas is, we're very lucky to have her here. She's well known on Twitter and well known in the academic circles, as she is a national leader in diversity, inclusion, and equity, having earned a PhD studying these topics at Stanford University. Dr. Salas is also a surgeon with extensive lived experience as a woman of color working in a male-dominated environment. Her research focuses broadly on gender equity, implicit bias, diversity, inclusion, and physician well-being. Dr. Salas is a prolific researcher and writer, having published in many medical journals, as well as speaking and publishing for broader audiences. She is also passionate about helping workplaces such as the University of Toronto Department of Surgery better support marginalized people. We are very lucky to have her here today to speak to us about the consequences of implicit gender bias on women's careers, especially in surgery. So with no further introduction, Dr. Salas, take it away.
Trying to do the unmuting and the go to presentation mode at the same time never works well because they're at opposite ends of the screen. But thank you so much for the kind introduction and for inviting me here today. Perfect that we had Dr. Wallace go over that study, because I was not going to go over it in detail, although I'm going to reference it for sure. So let's just get right into it. Just a couple disclosures to start off. I do some consulting work with Intuitive Foundation and Intuitive Surgical. Intuitive, as many of you know, is a surgical robotic company unrelated to the content of today's talk. I'm also a collaborator with Exponential Talent, which is a diversity and inclusion consulting firm. I also added some personal disclosures here, which I do often in talks like this, because we all bring to every arena that we go to our own biases and personal sets of experiences, and those are the lenses through which we view the world. So I think they're important to disclose. So I'm a cisgender woman. I'm also an immigrant, born in Iran and moved to the US when I was very young, 5 years old. But being an immigrant is definitely a big part of my identity. And I happen to be have a heterosexual sexual orientation. And again, I just share all this because all of this influences the way that I've experienced the world and how I come to you today. So starting out, I usually, whenever I'm going to talk about bias of any kind or disparities, I start out with, in terms of careers, disparities in careers, I start out with, why does it matter? Because a lot of times people will say things like, oh, well, if you face microaggressions or whatever, like, so what? Suck it up, move on with life. Everyone's an adult. These aren't the things that matter. What really matters is the patients. And Dr. Wallace really introduced this idea very nicely by saying that actually, this is what matters for patient care, that if we don't have a diverse enough workforce, we're not going to have the best possible outcome. So he highlighted his study, and then the heart disease study that I was going to mention here. But before I get to that one, I wanted to share that also we know there's a lot of data on concordance with patients, and we know that patients prefer to be cared for by people who look like them. They're more satisfied with the visits, and they're more likely to adhere to treatment plans. And then specifically that study with heart disease that Dr. Wallace shared, one thing I always like to add about that study that was really interesting was not only did patients treated by women physicians have better outcomes, but actually having more women in the emergency department improved the outcomes for all women patients, even if the individual physician they saw was a man. So there's some added benefit just to having more women in the workplace. And then racial concordance data also exists. There's multiple studies on this, but one I'll just share is related to newborn mortality. And the same group who had done that heart disease study also did this work published also in PNAS, showing that the infant mortality gap, the Black-white infant mortality gap, meaning that Black infants are more likely to die than our white infants, decreased significantly if the physician caring for these newborns was Black. So Black physicians taking care of either white babies or Black babies, similar rates of mortality. But when Black babies were taken care of by white physicians, they had significantly higher rates of mortality within those first 30 days. So all of this suggests that if we really care about the quality of patient care we're providing in our organizations, then we really have to care about who is showing up in our workforce and who are we selecting and who are we supporting in our workforce. And if we're not supporting people from all different backgrounds, then we're really doing a disservice to our patients. So I'd just like to pause here for 1 second, since today we're talking about gender specifically. I wanted to just see if people would maybe indulge me here and write some things in the chat. Like, what do you think is the most important thing that we need to change if we're going to achieve gender equity? Is it a policy issue? Is it time that needs to go by? Is it more women leaders? Like, what do you all think? And I'll just wait here and see what folks have to say. Equal opportunities that are transparent. Yeah, transparency is so important. Thank you. Mentorship, intersectionality, parental leave, early education, management of macro and microaggressions. Yep. Promotions processes. Exposure to role models. Yeah, these are all great. There's no one right answer to this. I'll share with you at the end what I think is the most important, but awareness of our own implicit biases, allyship, yeah, all important. Thank you for sharing those. So we'll talk from here to the end of my portion of this session. We're going to talk about some definitions and then go over some empirical data and try to end with some solutions, as well as covering, of course, the impact. So I'll just start out with this graphic, which many of you may have seen. This is a couple of years old from the AMC, and they haven't updated the graphic yet, but the same idea holds true even today, which is that we have quite a few women in medical school, and at each level after that, we see drop-offs. And sometimes when people look at these data, they say, well, all it's going to take is time. It's only been the last, 5-ish years that we've had similar numbers of medical students be men or women. And so if we just wait long enough, they'll make their way up through the ranks. And it's actually the case that women have been 45% or more of medical school classes since the late 1990s. So even though we hit the exact 50% mark more recently, we've been very close to it for a couple of decades. And yet we see that even at the level of just all faculty, it's shown here 41% are women, but when you look at full professors, an even smaller number, right? 25% are women, and then department chairs and deans at around 18%. I think the more recent data are about 20%. But still a huge difference between who's showing up in medical school and who's making their way through our academic ranks. And of course, there are multiple reasons for that sort of drop off, but I would argue that bias and sexual harassment and microaggressions are definitely part of the reason that women end up leaving this pipeline. And I think that, to somebody's point in the chat too about intersectionality, we can't really talk about gender without also talking about race, because these two together really impact how the world sees us as individuals. And of course, there are other factors like our religion or our ability status or sexual orientation that also influence how people interact with us. But some of those are less visible. So I wanted to share these data from the New England Journal that looked at matriculation into medical school. So this came out last year. And what they did that I thought was really a nice way of looking at it was to look at 1980, the year 2000 and 2019, and to look at what is the representation of each of these race and ethnicity groups compared to, this is US data, so compared to the US census representation of those groups. So the middle of both of these graphs is the US Census representation for each group. So bars extending to the right are groups that are overrepresented in each particular year, and then extending to the left are the bars where groups are underrepresented. And what you see is that, for example, for Hispanic women, we're about the same level, maybe a little bit better, slightly representation as compared to 1980. So not really showing any improvement there. Black women, it seems like maybe a little bit better represented now than in 1980, although a little bit less represented even in the year 2000. And then American Indian, Alaska Native, Native Hawaiian, Pacific Islander women, far less represented now than ever before. And then for men, you see even more striking, you see fewer Black men, or more underrepresentation of Black men, more underrepresentation of Hispanic men, same with American Indian, Alaska Native, Native Hawaiian, and Pacific Islander. So this really goes counter to kind of our own natural thinking and intuition that things will become more diverse over time. And in fact, what both of these sets of data about gender and race show is that, in fact, if we don't make intentional efforts and do something to change the way that we do admissions, the way that we do promotions, and so on, we will not actually continue to see diversification, which I think many of us would argue is what is desirable. So I just wanted to share here too some numbers outside of medicine, because these are the same, as Dr. Wallace was saying earlier, these are the same phenomena playing out throughout our society. This isn't just a medicine issue. It's not just a surgery issue. So these data are from the McKinsey Women in the Workplace report that comes out every year. So this is from 2021. And I want to draw your attention to this left figure, where basically they look at entry level all the way up to C-suite, and they look at the representation of these different groups of people. And the first thing that really pops out at me is if you look at white men, 35% of entry level positions are held by white men. But when you go up, you're seeing more and more, a greater and greater proportion of those roles being held by white men, up until C-suite, where 62% of those roles are held by white men. So it's almost like we're concentrating white men. If you think back to chemistry, we're like selecting for, amplifying, concentrating white men. And then when you look at men of color, there's a decrease from 17% to 13%. But when you look at women, it's even more striking, right? So you start out with, even if you just look at white women, 30% of entry-level jobs being held by white women, and then dwindling down to 20% of the C-suite jobs. For women of color, it's even a more severe decline, right? We're starting out at a not so high number, 17% of entry-level jobs held by women of color, going all the way down to 4% of C-suite jobs. So this is the same exact trend that we're seeing in medicine playing out in the business world. I just don't have those women of color data exactly for medicine, so that this is helpful for showing that. And so often people will say to me, well, how do we know what's happening? You know, how do we know how much bias we have? And to be honest, there's not a great measure. By now, most of you have probably taken these implicit association tests, which are very popular, hosted on implicit.harvard.edu. And these exist for all different types of characteristics, including the ones I've listed here. And I mention them because they're really kind of the main measure that people use. It's got flaws. The IAT has definite flaws. You can read about them if you just search for like what's wrong with the IAT. There are many methodological issues, yet it is the test that has the most data behind it, and that's been used most widely. So the reason I'm mentioning it here is that a few years ago, we wanted to know what's the level of gender bias in our healthcare organizations. Can we get some sort of assessment of that? And so what we did was we took the gender career IAT from that website, which the two gender categories are male, female, and then the career side of it is career versus family. I'll just pause for 1 second and say that the IAT, much like a lot of the other data that we have related to gender equity, uses a binary gender framework. We know that there are more genders than just the two, but most of what I'll talk about today, or almost all of what I'll talk about today, is using this binary framework only because that's the data that I have to work with, not because I'm endorsing this particular framework for gender. So the IAT, like I said, the gender one, male, female, and then career, family. And what we did was we wanted to look at the healthcare workers specifically who had taken that IAT. So there were about 43,000 healthcare workers who had taken that IAT in an 11-year period. And then we looked at the responses just for those folks to get a sense of where do we sit within healthcare. And then we created a novel IAT, which we call the gender specialty IAT, very similar to the gender career IAT, male, female again. And then instead of career and family, we had family medicine and surgery. And that one we gave to or administered to surgeons only. So I'm going to share with you the results of both of these data sets. So the line where 0 is, that on the on the vertical axis, that would be if people were sitting right at neutral, no preference for one way or the other, no greater association for one gender with a different career. And you see that immediately that all 4 groups, both men and women in the gender career IAT and the gender specialty IAT, are well above that 0 line. And this indicates that in the gender career IAT, both men and women are more likely to associate men with careers and women with family. And again, these are folks in healthcare. And then on the right, both men and women surgeons are more likely to associate women with family medicine and men with surgery. And this matters because of how we're perceived. Those of you, especially who are on social media, have seen the countless stories that come up of women, and especially women of color, saying they were mistaken for some other member of the team, whether it's environmental services or a nurse or something else, or stories are out there all the time about how patients will say, when am I going to see the doctor? Or how come no doctor has seen me today if they're inpatient? As a woman surgeon myself, I've definitely had the experience of patients at the end of a visit, after I've explained everything about their problem and the risks and the benefits of surgery and described the surgery in detail, will say to me, but who's going to do the surgery? Because it's somehow confusing that a woman could be the one to do it. And so these are barriers that we face all the time and contribute to what they call role incredulity, right? People not believing that we are the doctor or the surgeon when we walk in the room. And I would argue that these biases, like I said at the beginning, it's not just that they exist and we don't like it. They really lead to meaningful differences in how we're treated. This is a study that we did looking at surgical societies. And what we did was we looked at 14 different surgical societies and looked at 2 different years of their annual meetings. And all we did was look at their plenary speakers. So these are talks where it's one person, usually an hour long or so, usually a high honor. And then we looked at all their panels, and that's anytime there were 2 or more speakers, and they were not related to abstracts. So we did not look at any of the scientific sessions. So just looking at who do people think of as experts and who are they inviting to serve these roles. And on the left, just looking at the plenary speakers, the blue parts of the bars are male speakers and the peach parts are the female speakers. And what you see is that almost half of the meetings had 0 women plenary speakers. And I should note that across all these societies, about 1/4 of the members were women. So it's not that there are no women around, although for sure we don't have as much representation in surgery as we do in, say, pediatrics. But still, 1 out of 4 members of these societies are women, and yet half of the societies had 0 women plenary speakers. And 1/3 of the societies had 0 women in both of the years that we looked at. So even across 2 different conferences, they could not identify any women or did not identify any women to speak. And then when we looked at the males, what we saw, which is on the right, is a wide range, with some societies in their annual meeting having 0% males and others having 100%. So for example, if you look at Society B, 100% males in both of the years and 0% plenary speakers who are women in both of the years, right? So they're really kind of knocking it out of the park, if you will, at excluding women. But other societies did better. And what was important to us about this work was to feed back these data to these societies so that they could understand where they sit compared to their kind of counterparts in the profession. And also, one of the things we found doing this work, I should have mentioned, I apologize, that the black hash marks on the left are the percentage of women members in each of those societies in those years. But what was really interesting too to find out was how few of these societies actually were tracking even who their members were. So not all of them even knew the breakdown of men and women in their membership, and they definitely didn't have race data, which is why we don't have that in this study. So some of them we were able to get membership lists and then look up those members. But all this to say that if you don't even know who's in your organization, how can you possibly know that you're serving their needs? And I think that these organizations, several of them, were not doing that. And despite all of this, the lack of recognition and the bias that we face, we know that women are taking on important work. We've known this in academic medicine for a long time, that women are more likely to take on service work, that women are more likely to take on education and mentorship roles, for example. These data, again, from the Women in the Workplace report, show a couple different areas where women are also taking the lead, which are more recent interests, right, for organizations. One is DEI, and then the other is well-being, supporting workers' well-being. And so what they found was that whether we're talking about the manager level or the senior leadership, women were more likely to take on both DEI work and well-being work, which I'm sure is not surprising to anyone here. What's most upsetting about this, though, is that these organizations, by and large, agreed that this work was important. So 87% of the organizations said that well-being work was critical to their organization, and 70% said it was DEI work was critical to their organization. And yet only 1/4 of these organizations actually formally recognized the work that people were doing. And those people, the majority of them were women. And so women are doing work that matters to our organizations, but when that work is not formally recognized, when there's no title, when there's no time, when there's no compensation for it, then really what we're doing is taking a hit, because it's going to impede our career if, for example, we're in an RVU-based compensation model and we're doing work that doesn't have RVUs associated with it, even if that work is critical to the success of the organization. Another thing I wanted to point out that I thought was really striking from this report, and I think this is the last thing we have from this report in this talk, was looking at the level of microaggressions experienced by folks. The reason I wanted to share this is often people think that microaggressions and bias and these types of things really only impact people at the junior level. And that's bad enough, even if that were the case. But what these data show is that actually women who moved on into senior leadership roles were more likely, not less likely, more likely to be interrupted or be spoken over, to have their judgment questioned, and have people comment on their emotional state. So it's not like, okay, we can put our noses down, work really hard, get through the training period, maybe get through junior faculty, and then we're in the clear. No, it actually seems that these things really ramp up as we progress and move forward in our careers. And we know that women's work is undervalued in a number of different ways. So I mentioned to you already, those the DEI work, the well-being work, education, mentorship, all of that is undervalued by our organizations. But we also know that the way that we evaluate the work of women is not unbiased. So when we look at the data from grants and the reviews that are written about grant submissions, we find that, and this is from Molly Carnes's group at University of Wisconsin, we find that words like innovative and leader and talented are more likely to be used in the evaluations for grants written by men. And also they looked at, in a different study, they looked at those grants who had been funded. So all the grants that had met a specific bar for funding. And they found that in those evaluations, there were actually more usage, there was more usage of those words for women than for men, suggesting that perhaps the women had to meet a higher bar, had to have better work in order to meet that same bar for funding. And then we see this play out as well in letters of recommendation, where people are more likely to use doubt inducers in the letters written for women, where they say things like, she seems like, or I think she will, instead of kind of the more strong statements that they often make for men, saying things like, he is a future leader in academic surgery, or he will be a future leader in academic surgery. People just don't make those statements as often for women. They just tend to hedge their bets a little bit, which of course it affects how people view those candidates when they're reading these letters of recommendation. And so at this point, somebody might be listening to all these data and saying, well, but maybe women just aren't as good as men. Maybe their grants aren't as good. Maybe they're not as good speakers. Maybe they're not really experts as much. And so we shouldn't be appointing people to things when they're not qualified, right? We shouldn't fund people who have bad ideas just because they're women. Totally agree. But the data suggests that actually that's not what's happening. What's happening is our biases are impeding our ability to actually fairly evaluate folks. So when we take the numerous CV studies that have been done, that's a really good test of like, how do we evaluate a person? So basically, for those who don't know, they take the same exact CV and then all they do is change the name at the top. And then they send it out in response to job ads, or they send it out and ask people to answer some questions about how talented they think the person is, whether they'd be likely to hire that person, and so on. And what these studies show is that if the name at the top for the exact same CV, if the name at the top is Jonathan, Jonathan is more likely to get an interview. He's more likely to be thought of as hireable. He's likely to get hired at a higher salary than if the name is Jennifer. This is, again, the same exact CV, and we see racial and ethnic differences for this as well, where Greg and Emily are more likely to be interviewed than are Lakeisha and Jamal. And this points to the fact that we just are not able to overcome our own biases when we're evaluating folks. And the same thing was found with the orchestras. I'm sure many people are aware of this, that women were not being selected for orchestras, and then they put up curtains so that the evaluators could no longer see who was performing, and that increased the likelihood of women being selected by about 25%. And then further after that, they actually asked performers to remove their shoes so that they couldn't hear the clicking of women's heels, and that helped even more. So again, these data point to not the case that women aren't as good, but that women are just as good, maybe even better. I'm going to talk about that in a second, but we can't see it. And so this is where I wanted to reference Dr. Wallace and Dr. Jarrett's work, which is contributing to a literature that's out there suggesting that women may take better care of patients than do men. And there's a lot of reasons to think this might be the case, related to following guidelines, being more likely to involve others, specialists in the care of these patients, spending more time with patients, thinking more about social determinants of health, et cetera. And so we wrote this piece, Anne Blaschke and I, she's a historian, we wrote this piece about kind of jumping off of Dr. Wallace and Dr. Jarrett's study to talk about the sexism that persists in medicine. And for us, really what's striking is, if we can, as women physicians, have really excellent outcomes despite everything that we're facing, what could we accomplish if we didn't have to overcome those barriers? What kind of care would we be able to provide if we didn't have to deal with sexual harassment, microaggressions, implicit bias, et cetera? And I'll just do a quick pit stop here on COVID because we are still, despite what some may think, in a pandemic. And COVID really has had a devastating impact on the careers of women. Some of this is related to, especially early on, the changes in domestic responsibilities. We all know we were spending more time at home and kids were being homeschooled in many cases. That responsibility for that extra work disproportionately fell on women. There was one study early on that estimated women were spending 2 hours more a day engaging in that kind of care work than were their partners, even in couples where people are both working. So of course, this has had some impact on productivity. And this is true whether you're looking at grant submissions, or you're looking at publications, or you're looking at manuscripts posted to preprint servers. All of this shows that while men were in many cases, or on average, more productive, especially in the early parts of the pandemic, women's productivity was not able to keep pace. And of course, the more time we spend at home, the more risk there is for intimate partner violence. And then I think this is the last thing I want to touch on before we go into some solutions, which is the double bind. And the reason I mentioned the double bind is that I think it is an undercurrent for almost every interaction that we have as women in the workforce. And the basic idea of the double bind is that there are characteristics that we as a society associate with leadership. These are things like being assertive, being direct, being confident. There are other characteristics that we associate with being women. These are being feminine, kind, and nurturing. And because we have these gender schemas where we expect out of women, but we expect actually of men that they act in the same way as those leadership stereotypes. So we expect men to be direct, to be assertive, to be confident. What that means is that for men showing up in the workplace, what society expects of them based on their gender aligns with what society expects of them as a leader. For women, that's not the case. What society expects of us as women is very different from what it expects of us as leaders. And so if we show up in a way where we are direct or confident, as many of you have seen, there is a social penalty for that. So we are left to kind of walk this fine line of how to be confident enough and assertive enough to be seen as leaders, but not so confident and assertive that people say we rub them the wrong way, right? Which happens all the time, or call us worse names that I'm sure you've all heard. So here's a few different ways that the double bind plays out. One is specifically related to confidence. So this was a great study done in an engineering firm. And what they did was they asked employees to kind of evaluate each other's confidence and influence within the organization. And what they found was that for men, the more confidence they had, the more influence they had in the organization. For women, that was not the case. For women, the more confidence they had, the less influence they had in the organization, unless they exhibited what the researchers called pro-social behaviors. So if they were checking on other people, helping other people succeed, having this kind of support of others mindset, then their confidence did translate into influence. And you can see how it's not necessarily bad to check on other people, right? And care about other people's work. But that's additional labor that was expected of the women that was not going to have its own reward, again, in compensation or a promotion or anything like that. But if they didn't do it, there was going to be a penalty. We see a similar thing play out with displays of anger. This was a study where they showed videos of either a man or a woman reading the same exact script with the same exact tone. And that's even as judged by the participants in the study. They judged them as having the same exact tone. That when it was a man in the video who was angry about something a coworker had done, then he was thought of as being justified in his anger because this other person had made a mistake. And so, of course, he would be angry. But when it was a woman, people didn't think that she deserved her role. People also attributed her anger to an internal source. So rather than the way they did for the man, say, well, of course, he's angry. This other person made a mistake. For the woman, they said, well, she's just an angry person. And you can see how that would really affect our trajectories and our careers if people think of us as angry people every time we express frustration about something that is not right. And we all know that in our healthcare workplaces, there are many things that are frustrating and get in the way of patient care. And the last point here is about how we judge people's errors, which is to say that we judge women's errors more harshly than we do men's, especially when women are in male-dominated professions. And so there are many examples of this, but one that some of you may be aware of is looking at referrals. So this is another Canadian study where they found that when people referred patients to a women's surgeon and there was an unexpected bad outcome, those same people then stopped referring to all women surgeons. So it wasn't just that they made a judgment about that one surgeon, which you could argue they shouldn't do that either, but it wasn't even just that. They went beyond that to saying, that's it, I'm not referring to any more women. Whereas when they referred to a man surgeon and there was an unexpected bad outcome, there was no change in the referral patterns. So you see again how we treat women differently than men, even for the same exact thing happening. And so what can we do about this? I'm just going to briefly touch on a few kind of characteristics of upstanding and then talk about a couple more things, and then we'll go into our Q&A. So in case folks have not done any sort of upstander training, the upstanding is the idea, let me just back up and say it's the idea of when you witness something that you're not just going to stand by and see it happen, whether it's a microaggression, whether it's someone getting an opportunity over someone else who maybe deserves it and so on, you're going to actually speak up in some way. So that's the idea of upstanding. And the 4 Ds of upstanding go back many, many years and are related to or came out of the work on violence on college campuses. So these are to distract the person. You can imagine that might vary from changing the topic to knocking over a trash can to, even if it's really bad, pulling a fire alarm or those types of things. Delegating, calling someone else to help. So if you're a trainee on a team, for example, you may ask your attending to intervene, or your program director or somebody like that. Or if you're a junior faculty, you might ask a more senior person, for example. Direct is the one that I think is most useful for people who are in positions of power, and anyone on this call now who's a faculty member, I would say you're in a position of power. So that's really just directly addressing the person and saying, hey, we'll talk about on the next slide what you can say, but I noticed this comment that you made, and it can be at that moment or it can be later on, and then kind of helping them understand why the comment was harmful. And then delay is alluding to that idea that you don't have to be an upstander in the moment necessarily. And in fact, there are many times when speaking up in the moment may not be appropriate, but you can still check in with folks later on. And then documentation also can be very useful. If we all think back to 2 years ago with the George Floyd trial, or murder, sorry, in the US, when that case went to trial, one of the key pieces of evidence was a video that was taken by one of the witnesses. And so that is a form of upstanding as well. So in the case of a direct intervention, if you are seeing someone, let's say they're untitling a woman physician, or there is some role incredulity, or even something more overt, like passing over all the women for the next opportunity, that's a leadership role, for example. This is just one framework for how to respond. There are many out there, but this is from the Southern Poverty Law Center, and it's to interrupt the person, like they say in this example, hold on a second, and ask a question, right? So coming from a place of curiosity, what did you mean by that? For example, if you think about someone like the former president of Harvard saying that women aren't as good at math and science, right? Like that our brains naturally don't do math and science as well. Someone could have said, hey, wait, what do you mean by that? You may not be aware, but actually there's no data that suggests that that statement is true, right? And you can see why with that kind of approach, you may or may not want to do it in the moment, because the last thing we want is to put people on the defensive, right? As soon as we put someone on the defensive, they're no longer engaging in the conversation. And whether and when to speak up really depends a lot too on your relationship with the people involved. And if it's a one-off thing with a patient, right? We often hear inappropriate things from patients. If it's a patient in the emergency room that you're never going to see again, it may not be worth it to engage. And we can't engage on every single thing that we see, right? Because these types of things are happening all day, every day. But especially when there are learners involved, especially when we're the person who is in a position of power in the situation, if we don't say something at some point, then what we're suggesting is that we're okay with whatever it was we just witnessed. And I think that's where the damage really can come into play. So back to the question I asked at the beginning about, what is one thing that we should change if we want to achieve gender equity? So to me, and you're probably going to say this is a little bit of a cop-out, but to me, the biggest thing is the culture. Like we have to change the culture. Policies are great and they're part of how we do that, but we have to develop a culture of belonging, respect, and justice in our organizations. Part of the way we can do that is by starting to flatten the hierarchies. There's a reason we have hierarchies in medicine and in surgery. At the same time, the steeper that hierarchy is, not only do we know from patient safety data that we're less likely to provide the best care, but also we're not going to be able to retain different people who may not be accustomed to that hierarchy or feel comfortable in it. We need systems that truly support survivors. We do not have that currently. In most places, reporting any sort of harm is punished rather than supported and cherished and celebrated. So we need to do more work like the Center for Institutional Courage and really encourage our organizations to have courage and to believe people when they speak up, because it takes a lot to do that. It takes a lot to report a concern. And we need to value that people care enough about the organization to raise a concern. Transparency was mentioned earlier. I think transparency and accountability really are cornerstones to all of this work. Without both of those, really nothing else matters. Because if we don't know, for example, how much are people making in this organization? How is anyone going to advocate for themselves, right? How are people going to know, for example, that they should have been considered for a leadership position if there was never a posting of that position, there was never a description of that position, so on. So we have to really be looking closely at who are we giving leadership positions to, who are we giving awards to, who are we uplifting in our organizations and why? And do we have equitable access to those opportunities? Because in most places we do not. And then if not, what are we going to do about it, right? That's the accountability piece. And nobody really knows exactly what training is the right thing to do. But I think that we can all agree some training is important, right? We're not going to make change without training people on these basic ideas of what are microaggressions, what is implicit bias, what is sexual harassment, and why are all these things inappropriate? So some kind of training needs to be done. And then we have to measure outcomes. I think this is where a lot of places fall flat, is not really treating this the same way that we do all other work that we do. So if we're going to change our preoperative antibiotics, for example, because we think that it's going to lead to better results in terms of wound infections, then we would track our wound infections, right? And see whether that worked or not. So it's the same idea here. We have to measure our outcomes. And then this is the last point here, which is for individuals, because not everyone is in a position of leadership where they can make sure that their department, for example, has accountability and transparency. But every single one of us has actions that we can take aside from the specific things I talked about with upstanding. These are things like amplifying women in meetings. We know that women are more likely to be interrupted in meetings than are men. And so it doesn't have to be contentious or raising up conflict, but it can be something as simple as, oh, I'd really love to go back to that idea that Angela was sharing. I'd love to hear more about what she was saying. And this works in the same way with, you see here, appropriation and giving credit, that we know in meetings, sometimes the ideas that women raise aren't really heard until a man raises that same exact idea. And so that's another opportunity in particular for men to say, hey, I love that idea that Angela shared, and I wanted to go back to that. Instead of just bringing up the idea and carrying on as if it were their own. This next point about assumptions is really important. There's a type of benevolent sexism that many of us engage in, and it's called benevolent because we think we're doing a good thing. And that's things like, oh, Jennifer has just had a baby. She's not going to want to take on this responsibility. Or Joanna is taking care of a sick family member. She's not going to want to take on this leadership opportunity. And the thing is that instead of making those assumptions, even though they're coming from a benevolent place, what we really need to do is respect people's autonomy and understand that Jennifer or Joanna can very well make a decision for themselves, right? They are adults. So if there's an opportunity that we think is appropriate for someone, we should offer it to them and give them the chance to say, oh, thank you so much. I just can't take that on right now, rather than making the decision for them. And in fact, many times they may step up and say yes. And then avoiding mansplaining. Of course, mansplaining is explaining women's experiences to them. So not doing that is good. And then the last point here is sponsorship. This one's really important because I think a lot of people focus on mentorship, which is great. Mentorship is, telling people what they should do. You should apply for this. You should meet with this person. You should write this paper, so on. And sponsorship is really talking about those people. It's saying, I would really like to nominate this person for this award, or I was asked to speak, but I'm going to pass that opportunity on to someone else. Or I was asked to write a commentary, and I'm going to either pass that opportunity on or invite someone to join me. And we know from past data that men are more likely to be recipients of sponsorship behavior than are women. So we all need to be more mindful of sponsoring women. And back to the point that I raised at the beginning, we know that all of these things impact women of color more so than white women. And so we have to be mindful of that and take an intersectional approach all the way. So I'll pause there, and then hopefully we can have a nice conversation. Thank you.
Thank you so much. That was fantastic. I have all these notes written all over my piece of paper here of all these ideas and questions that I'm hoping that we can discuss during the panel. But I thought what we would do next is open up our panel. So I've already introduced Dr. Christopher Wallace, as well as Dr. Arga Gonzalez, who just spoke. We also have a third panel member, Dr. Angela Girath, who we're also honored to have join us today. She works with me at Sunnybrook. She's a cardiac anesthesiologist and also a very well-known researcher, and is a co-author on the paper that Dr. Wallace introduced towards the beginning of today. Her research is funded by national bodies, including CIHR and the Heart and Stroke Foundation of Canada. She uses epidemiological methods to evaluate impact of care models on patient and health systems outcomes for complex surgical and critically ill patients, and introduces new care options to improve healthcare delivery and patient recovery. So thank you very much for joining us. And with that, we'd like to use the last 15 to 20 minutes really to open up a discussion. Anyone in our audience, if you'd like to ask a question, make a comment, or direct the panel towards a certain topic, please add a note in the chat. I'm going to try to monitor the chat as well as the Q&A section, but it'll be easier to see your comments in the chat. So if you don't mind putting any comments in there, that would be great. I can get us started since I'm really fascinated by a lot of the topics that you brought up and that Chris brought up at the beginning. But I think that you really did a great job, both of you, in really showing us and linking the impact of implicit bias that we have in surgery and in medicine, and how that implicit bias directly impacts patient care, and how important, it is that we start to recognize some of these biases in order to give our patients the best potential outcome that we can. My question is about culture change and what you spoke about a little bit at the end of your talk. And in surgery, we're very much in a multidisciplinary environment. So we work in the OR and we have surgery, we have patients, but we also have anesthesia, nursing, PSWs. We have in our office, we have our office assistants who are triaging our consults and maybe returning referrals or divvying up consults, etc. So some of the issues that we talk about with respect to implicit bias and culture change are not just things that we can control ourselves, but things that we maybe have to introduce in a multidisciplinary way. So my question for anyone on the panel is, what would you say, how would you address changing culture in these multidisciplinary environments? How can we approach that in a bigger way?
I can just start and then yield the floor to others because I've talked a lot. But I think that there is a place for perioperative educational efforts, right? I've had people from different institutions actually come to me and say they're wanting to improve the culture in the OR. And they're acknowledging that, as you said, it's all these different groups of people coming in. And so we can unite those folks through like our perioperative services or some similar office that most places will have, and get folks on the same page in terms of what is acceptable behavior and what are the inequities that we see there. For example, we know, like experientially, we know that often women surgeons, when they start, are not treated the same way as men's surgeons. In fact, I was on a call a couple of weeks ago with a woman who's a chair in one of the departments, one of the surgical departments here. And she said that when she first got here, she was shocked at how poorly she was treated, even when she arrived as the chair of the department. But in the OR, she would have techs who didn't respect her, wouldn't get what she needed, and so on and so forth. So we know that women, especially when they start at a place, are not afforded the same level of respect as our men. And that's very much a perioperative issue. And we know that often they'll be assigned scrub techs who are not from their specialty. They'll be assigned rotating scrub techs rather than consistent scrub techs, and circulators and so on. So all these different layers that will make it harder for women to actually do their job successfully. So you're starting out at a new place, you're already anxious about it, especially if it's your first job out of training. And now you've got all these additional, it's hard enough, right? And then you've got to overcome all these additional barriers. It's a real setup that really can be solved at the perioperative services level, not at any individual department level. I'll stop there.
Thanks. Does anyone else have any comments about that?
I think culture change is integral to this, but it takes time. I think back to my youth, and I've been fortunate or unfortunate, however you want to see it, to see how that gay movement has now been gone from being in the shadows, obscure, treated poorly, illegal, to something that's now mainstream, in policy, allowed to marry and to have children and to live normal lives. And the question that really irks me is, how do you incentivize change here? Because you've got to have skin in the game. Both men and women have got to have skin in this game. And the conversation does have to shift. Probably, it's a mutual thing that's going to go on, because women have entered the workforce from the 50s and slowly changed where they are. And we're all having to shift. There's a ton of confusion right now. And, we need to have those conversations. We need to be building better collaborative teams perioperatively at the levels of our products outside the operating room, throughout medicine, and learn to kind of work together and having multidisciplinary teams wherever they are, and for it to be rewarded and for it to be acknowledged. And Argovan's spot on. Sponsorship, there is no substitute for it.
Mhm. Great.
I'd say
We
just one quick thing. I like to step outside of medicine when I sort of look for examples, and there's a good example in the business world um, that shows when women or visible minorities advocate, even when they're in leaderships for women and other visible minorities, they're demonstrably punished. When white men advocate for women or visible minorities, there's no punishment. There's not, at least in that example that I have, a demonstrable gain, but there's certainly no punishment. And so, you know, it's part of the reason why I care about this work so much, because I think there is a real tendency in society to make the groups that bear the burden of inequalities in our society be the ones to do the work to shift those burdens and to address the inequalities. And I think that we have great examples. There's an implicit logic as to why that's unequal, unfair, and unjust, but there's also empiric data to support that. And so I think fundamentally this situation is not going to get better. Argovan's highlighted the data that time doesn't just change it. Many of my senior male partners will tell you that you just need to let time play its course and things are going to get better. And I think fundamentally it's just not true. We have to care, and the people who benefit the most from the current system have to care and be willing to change it because they believe that that's the right thing to do. And until that's true, I don't really think we are going to make that much progress. And so one of the conversations Dr. Jareth and I have had recently is, how can we change the hearts and minds of people who don't see this as a problem and don't see it as something that needs to change, probably because the system benefits them. Do we have to wait those people out, or can we actually do something?
Laura,
Thank
maybe
you.
I'll add a comment on that comment,
Yeah.
maybe a question to the panelists.
Yes.
I think we're talking about medicine, of course, and surgery, which is very important. That's where we work. That's our area of interest. That's where we interact with other people and where we have influence. But I think maybe just a reminder that ultimately we are a microcosm of the society we live in. And so it's very important for us as surgeons, leaders, etc., to be engaged in the society at large, because ultimately the biases that we see inside our institutions are a reflection of the racism, the bias, the gender bias, etc., that exists in our cities and our communities. And so an unequal society ultimately will produce unequal conditions in every organization that exists within it. So I think that's a very important aspect that we, being very busy and maybe very narrowly focused on what we do, we may, or some of us, or because of conditions that we work in, forget about that aspect. And I think it's extremely important to remember that. I'm not sure if you have comments on that.
We also have a very busy chat, which is amazing. I love it. There's a bunch of questions in the chat. So is it okay, Najib, if I hop into the chat and we can keep going a little bit too? We have a question the first question from the chat is, I was hoping the panelists could touch upon their residency experiences and ways in which they think residents can advocate in their role while also acknowledging the hierarchies that exist currently in surgical culture.
I mean, I can start again on this one. I think that actually speaks to something Dr. Wallace was bringing up earlier, that residents in many ways are subjugated. And I don't think that anytime there are groups that are marginalized or minoritized or oppressed, whatever word you want to use, and it's different words for different situations, of course, I don't think those groups can be the ones with the responsibility of making the change. That's it. That doesn't mean that there's nothing residents can do. It's just that I think we have to acknowledge they're very vulnerable as a population. And so while they can certainly speak up, and I don't know if you all are following this case in Southern California, but the residents there had unionized, as many groups here in the States have started doing, as many residencies have started doing. And they actually threatened to go on strike unless they got a salary increase. And I think some, of course they had other things, but they were successful, I just saw, in getting a raise. So not to say that they can't do anything, it's just that I want to acknowledge they're in a vulnerable position. And of course, everyone they're working with has some evaluative role over them. And not only that, but also impacts their potential future career pathways because they need letters from those folks. And so I think what's tricky is that if we encourage residents to speak up all the time and to truly advocate for themselves, we have to be ready for them to do it, which means we have to not then judge them or punish them when they do that. And if we can achieve that, then I think it's great because residents know what all the issues are, right? Like they're closest to the ground, they're aware of a lot, and their mindset, just they tend to be younger, is a little bit different. And what they're willing to accept is a little bit different. And I think that's all for the better of medical culture. But we can't tell people to speak up and then punish them when they do. That's what the problem would be.
Yeah. Absolutely. We have a couple of other questions. So can you comment, so any of the panelists, on how we might inadvertently be contributing to benign discrimination against women surgeons by emphasizing how women surgeons are better communicators or otherwise attributing certain skills or capabilities to surgeons based on their gender? So I guess gender schema, how we're sort of perpetuating gender schema. Women surgeons often get more complicated and difficult patients, and patients who may not need surgery and remunerate less because they're perceived at being better with people. So there's a lot of issues, I guess, embedded in this question. But if anyone is willing to tackle this gender schema, maybe referral bias, and just overall bias with respect to expectations of how female surgeons deal with patients and how we can overcome that in a progressive or productive way.
I think Fahima Dosa's in the call, and I think her work better addresses this than certainly anything I've contributed. But I think it's pretty clear that the expectations of male and female surgeons are different. That comes from patients, but it also comes from referring physicians. And so, Dr. Dosa's work has clearly shown us that, women are more likely to get the non-operative referrals. They're less likely to get referrals, period. But among the referrals, they're more likely to get the non-operative ones in a fee-for-service model like Canada, or an RVU-based production model in the US. That translates into income inequalities. Certainly discussions like centralized referral patterns, where all referrals are sent in and then sort of distributed within the group, may address some of that because the referring physician can't tailor in the same way. I think there's a lot there's a lot more levels to addressing that, but that's at least my initial thought.
I did, Fahima, I did unmute you or allow you to talk if you wanted to add to that, because I saw that you're in the participant list.
Sure, yeah, I think
I don't want to put you on the spot, but
sure. I think Chris summarized things well, and yeah, certainly I do think that the cognitive schema that we hold for women and the social norms that we expect of women certainly do affect, at least in our work, we've shown that it affects how referrals get distributed and the types of cases that we end up allowing women to do, if I can phrase it that way. I mean, we've shown, as the question asker was speaking to, that women more often get non-operative referrals. Women more often get more complex patients, not from a medically complex perspective, but oftentimes from an interaction perspective. I mean, I do think we need to think about what we think women's place in surgery is. I think that as long as we are going to send certain types of referrals to women, we are making a comment about women's place in surgery. In general surgery, where I train, very much the message is women's place is in breast surgery, and women's place is in other areas where women patients are overrepresented. And it's no coincidence that the area that we say is women's place happens to be the areas that are under remunerated compared to other parts of the specialty. So I'm glad that the person asking the question has picked up on those complex factors where, certainly our cognitive schema are driving some of these referral biases that we see.
Thank you, Fahima. Now we have 1 minute left, and now I'm in the very awkward position of, do I choose the outgoing chair of the Department of Surgery's question or the incoming chair of the Department of Surgery's question for the final question? Maybe we'll try to answer both of them quickly, just so we don't do anything wrong here. Dr. Rutka asked for Dr. Salas, what are some of the solutions to achieving better gender parity in surgical specialties that have been heavily male dominated traditionally, like orthopedics, urology, cardiac surgery?
Yeah, thank you for that question. I just want to add something real quick to the last question, which is that I don't know how much this is happening in Canada, but there is this strong valuation of patient satisfaction scores, often in our systems here in terms of compensation. And I just wanted to acknowledge that those evaluations by patients are also biased. And those same expectations that are mentioned in that question of expecting women to spend more time, expecting women to spend or to explain things more and to a greater degree, also impact our ability as women to generate RVUs directly. But then when we try to move them along and try to have concise visits, then we get dinged on the patient satisfaction scores. So either those scores need to be adjusted in some way, or they need to not be part of our compensation packages. To this question of solutions for achieving better gender parity in surgical specialties that are heavily male dominated, I think really the issue is of culture, right? No one wants to go somewhere where they're not going to be accepted. Well, I shouldn't say no one, but very few people want to kind of push their way somewhere where it's clear they don't fit in. And ortho would be a great example of this, right? 6% of orthopedic surgeons are women. And I don't think that's because women can't do the work or necessarily aren't interested in the work, but they may not be interested in doing the work in the environment that they would have to do it in, which is an environment in many places that is male dominated with lots of, people will talk about bro culture. And so if those types of specialties want to attract more women, then they really have to change their culture, and they have to look inside. So what I hear a lot is like, oh, women just don't like ortho. I don't think that's true. There's a lot that goes into picking a specialty, right? And what is the work environment is a really big part of it. And so if people really want to attract more women, then they have to make the specialty appealing to women. And what does that mean? That means giving them a fair shake at success. That means not having an environment that's laden with sexist comments and sexual harassment and sexual intonations and kind of a lot of locker room talk and those sorts of things. And if those cultures aren't changed, then it will continue to be the case that a lot of people and many women will not feel comfortable in those spaces and will choose to go somewhere else instead. So that's, I think, the main thing that needs to happen. And then of course, outreach, right? Like having panels, having different organizations that are specific for, say, women in orthopedics who are trying to raise the visibility of those women who are there and saying we do belong, and all of those, kind of grassroots efforts are also important.
Thank you. So I think we could keep this conversation going for hours, but unfortunately we're towards the end of our time. So Najib, maybe I'll pass it over to you to maybe make some closing remarks. And if you can sort of tie in Dr. Swallow's question with your closing remarks, that would be great, because they reflected back to your initial comment.
I'm just looking at Dr. Swallow's comments quickly. Yes. So first of all, thank you, Dr. Salas, Dr. Wallace, Dr. Azal, for your contributions today. I really enjoyed the talks. I think the panel from the engagement clearly enjoyed it as well. I think it's very important because the issue of gender bias is this elephant in the room that I think most people recognize is there. But I think there are still some people that feel deny it or at least dismiss it. And the work that you're doing and that's been presented, I think adds evidence and shows tables and numbers, which I think we all can relate to, and hopefully make it much more difficult for people to dismiss this very important issue. And I think hopefully it gives tools to everybody on this call and beyond in our Department of Surgery, particularly given my role and Laura's role, to hopefully push for change on all the levels that you talked about, to hopefully accomplish a culture that's very different. I think we're making some headway, but we have a long way to go. And I hope that people take away from this session that change can be made and can be done, but it requires advocates and people who are can put their sort of leadership positions on the line to make that change. And as co-director of EDI, we want you to reach out to us if we can be part of that or can help with that. And hope that together we can hopefully make things better along the way. We will have more talks in the future, so please spread the word on this and join us for talks in the future. Back to Dr. Swallow's comments, it is a complex issue, and microaggressions definitely affect everybody, particularly the people that deal with patients and who reflect society. And I think, as I mentioned before, and given what the talks have suggested, there's a bigger social context to all of this. And as surgeons, we tend to be sometimes very tunnel visioned about things, because that helps us get the work done, given the difficult circumstances within which we work. But at the same time, we should all be very engaged on a larger level and be advocates for our own residents, our own communities, and the cities that we work in, whether it has to do with gender or other issues, because they're all interrelated. So maybe I'll stop at that. I'm not sure if anybody has any further comments, but thank you very much for attending and for taking time from your very busy and zoomed out lifestyles to attend one more Zoom talk.
Thank you, everybody. Thank you, everyone on the panel, so much for participating today as well. It was great. I wish we could do another hour.
Have a good evening, everyone.
Thanks so much. Enjoy your evenings.
Night, guys.
Bye.
Bye. Thank you.
And Chris, thanks for stepping up.
All good. My pleasure.
Yeah. Okay. Good night, guys. Thank you so much, Angela.
All right. That's
Thank you.
that's everything. We're all done.
That's a wrap.
All right. I will end it right
Thank
now.
you.
Thanks.
Thanks so
Have a good
much.
day. Bye-bye.
Bye.